Introduction. Contraception, also known as birth control, is a method of preventing pregnancy that stops sperm from reaching the egg. Birth control techniques can be used in a variety of ways in which condoms, diaphragms, cervical cups, and contraceptive sponges are examples keeping the ovaries of the women from releasing fertilized eggs. Birth control pills, patches, injections, vaginal rings, and emergency contraceptive pills are all examples. Intrauterine devices or IUDs are uterine instruments that are inserted that can be left in place for a long time, while sterilization is a procedure that permanently prevents a woman from becoming pregnant. The method of birth control you choose should be based on a number of variables. These factors include your health, the frequency at which you engage in sexual activity, the number of sexual partners you have, and your ability to have children in the future. Your doctor will assist you in determining the right method of birth control for you. When selecting the most suitable contraceptive method, several factors must be addressed by women, men, or couples at any point in their lives. These factors include protection, effectiveness, accessibility, and affordability, as well as acceptability. Contraceptive therapy, when available, can be a significant contributor to the effective use of contraceptive methods. And voluntary informed choice of contraceptive method is an important guiding principle. Dual immunity from the possibility of human immunodeficiency virus or HIV and other sexually transmitted diseases or STDs should be considered when selecting a form of contraception. Despite the fact that hormonal contraceptives and IUDs are very good at preventing pregnancy, they do not protect against STDs including HIV.
For the subjective chief complaint, my fiancé and I are getting married soon, and we're not ready for kids yet. History of present illness. Madeline Macy is a 24-year-old graduate student who presents to the Family Medicine Clinic for contraceptive counseling. She and her fiancé Fritz are planning to be married in approximately 3 months. Madeline states that she and Fritz have been in a monogamous sexual relationship for the past 2 years, and that their primary method of contraception has been via the inconsistent use of male condoms. She is here today to be evaluated for the use of hormonal contraceptives. The patient states she began menses at age 14, with irregular cycles of 25 to 36 days in length. Her last menses was 2 weeks ago. The patient states she has heard about contraceptive options that keep you from having a period, and she wants to know more about those options and if they would be okay for her to try. Past medical history. Migraine headaches without aura or focal neurologic symptoms, well controlled for the past 6 months on prophylactic therapy. Family history. Mother, aged 52, has hypertension and osteoporosis. Grandmother died from complications of breast cancer, which was diagnosed at age 60. Father, aged 53, has osteoarthritis, hypothyroidism, and hyperlipidemia. Grandfather died at age 74 of myocardial infarction. Social history. Currently lives in a house on campus which she rents with 3 other graduate students. Once she and Fritz are married, they plan to rent an apartment together until she finishes graduate school. She admits occasional social use of tobacco and alcohol, a few drinks and a couple of cigarettes at parties on weekends. Otherwise, she denies regular smoking or alcohol use during the week, and she denies illicit drug abuse. Medications: propranolol long-acting 160mg by mouth once daily for migraine prophylaxis. Naproxen 220mg, 1 to 2 tablets by mouth every 8 hours as needed menstrual cramps. Allergies: no known drug allergy. ROS: menstrual periods are the most irregular during exam times. Migraine headaches are not accompanied by aura or focal neurologic symptoms and have been well controlled on prophylactic medication. Patient states she has not had a migraine for more than 6 months. However, prior to being placed on propranolol for migraine prophylaxis, she reported experiencing menstrual-related headaches in addition to frequent migraines.
General: well-developed and well-nourished female and no abnormality detected. For the vital signs, the blood pressure is 116/74, pulse is 66, respiratory rate 13, temperature 37 degrees Celsius, weight is 56 kg, and the height is 5'6". For the skin, with mild facial acne, the head, eyes, ears, nose, and throat examination showed pupils equal, round, and reactive to light or accommodation, extraocular movements are intact, tympanic membrane is intact, and the oral mucosa is clear. For the neck and lymph nodes, supple without lymphadenopathy or thyromegaly. For the lungs, the computed tomography angiography showed no wheezing. For the cardiovascular, showed normal sinus rhythm, no murmurs, rubs, or gallops. For the breast, equal in size without nodularity or masses, non-tender. For the abdomen, soft, non-tender or no masses. Genital, urinary, and rectal, normal vaginal exam without tenderness or masses. For the musculoskeletal and extremities, normal range of motion and normal muscle strength. For the neuro, alert and oriented ×3. And for the labs, negative pap smear and urine pregnancy test. For the assessment, young, generally healthy, sexually active female with a history of migraine headache disorder that has been well controlled with prophylactic medication is requesting hormonal contraceptives for birth control.
One A. Create a list of the patient's potential drug therapy problems. The patient is Madeline Macy, a 24-year-old graduate student. She mentioned that she takes propranolol LA once a day for migraine prevention and 1 to 2 tablets of naproxen every 8 hours as required for menstrual cramps. Based on her medications, the interaction between two medications needs close monitoring. Naproxen plus propranolol. Naproxen decreases the effect of the propranolol by pharmacodynamic antagonism. Long-term NSAID use and NSAID decreases prostaglandin synthesis. Propranolol plus naproxen. Propranolol and naproxen both increases serum potassium. 1B. What medical problems are absolute contraindications to hormonal contraceptive use? And do any of those conditions apply to this patient? The absolute contraindications to hormonal contraceptive use are absolute contraindications for estrogen-containing OCPs. Cardiovascular. Under cardiovascular are thromboembolism, coagulopathy, or antiphospholipid antibodies, coronary heart disease, stroke, arterial hypertension, and heart defects. Metabolic. Under metabolic are pronounced hypertriglyceridemia, metabolic disorders of the liver, insulin-dependent diabetes mellitus with vascular complications or duration greater than 20 years. Oncologic. Under oncologic are heparin tumors and estrogen-dependent tumors. Example is breast. Inflammatory. Under inflammatory are acute pancreatitis, lupus erythematosus, vasculitis, and after herpes gestationis. And others, smoking more than 35 years of age due to significant increase in the risk of BPE, genital bleeding of unknown cause, pregnancy, and migraine with aura. Absolute contraindications for progestin only, known or suspected pregnancy, unexplained vaginal bleeding, breast cancer and cervical cancer, and suspected uterine infection. Absolute contraindications for combined hormonal contraceptive. Thromboembolic, coronary, and cerebrovascular disease or a history of it. Moderate to severe hypertension, hyperlipidemia, active liver disease, hepatoma or jaundice during past pregnancy, suspected malignancy of genitals or breast, porphyria, and impending major surgery to avoid excess risk of post-operative thromboembolism. Madeline is in a relatively safe state with a managed migraine headache. None of the medical conditions mentioned in her current history, physical examination, or test findings are relevant or present to the contraindication issues that may arise when using hormonal contraceptives.
The relative contraindications with estrogen only includes cardiovascular, superficial venous thrombosis, thrombophlebitis, and severe varicosis. For the metabolic, hypercholesterolemia, morbid obesity, and diabetes mellitus. And others includes age greater than 40 years old, epilepsy, migraine, smoking, lactation, uterine leiomyomas, gastric and duodenal ulcer, and ulcerative colitis. For the relative contraindications with progestin only, it includes active viral hepatitis, liver tumors, and diabetes. And for the relative contraindications with combined hormonal contraceptive, it includes diabetes, obesity, smoking, epilepsy, undiagnosed vaginal bleeding, mentally ill, mild hypertension, above 35 years old, gallbladder disease, and migraine. Based on the social history of the patient, she smokes tobacco occasionally that is relatively contraindicated when using estrogen-only contraceptive. Also, using the estrogen-only and combined hormonal contraceptive, it is contraindicated with patients having migraine without aura, just like in the case of Madeline. Consider the patient's choices and preferences. Patient autonomy allows the patient to decide on her own and on what method she is comfortable with. This will allow the healthcare professional to educate on what is essential, but does not allow the healthcare professional to decide on behalf of the patient. Financial capacity. Knowing the financial capacity of the patient can help assess the suitable intervention and can help the healthcare professional to come up with a planning option that is fit for the financial capacity of the patient without compromising the goal of treatment. Pharmacotherapy. Healthcare professionals must make use of their knowledge to prescribe what is appropriate for a patient that can provide their needs that can reduce expenses without compromising the quality of treatment. Drug-related problems. Before creating a healthcare plan, assessment of the possible drug-related problems within treatments is essential to minimize risk and maximize therapeutic benefits.
Desired outcome. What are the goals of the pharmacotherapy in this case? The pharmacotherapeutic goal in this case is to prevent or control unwanted pregnancy with the help of different hormonal contraceptives birth control available in the market. These contraceptives work by hindering the sperm from joining the egg and prevent fertilization. It has more than 99% effectiveness when used correctly, thus preventing unwanted pregnancy. It also helps to regulate normal menstrual cycle. Women who have irregular or heavy periods may benefit from this. Furthermore, contraception helps everyone to control when they want to start a family and the number of children they want.
Medroxyprogesterone acetate or Depo-Provera. Depo-Provera is a form of birth control. It is an injection or shot that contains progestin. It prevents pregnancy by stopping ovulation by thickening your cervical mucus, which makes it hard for sperm to reach the fertilized egg. It also thins your uterine lining, which makes it hard for a fertilized egg to implant or attach to your uterus. Some of its advantages are you don't have the hassle of a daily birth control method like the pill, since you only have to get Depo-Provera injections 3 times a year, then you don't need to think about birth control for months. Depo-Provera doesn't interfere when having intercourse, so it allows for spontaneity. Depo does not contain estrogen, so it can be a good alternative if you cannot tolerate estrogen or use combination contraceptives. One of its disadvantages is that scheduling is important. You must remember to make your injection appointment every 12 weeks. If it's been more than 13 weeks since your last shot, use a backup birth control method so you don't get pregnant. Many women stop using Depo-Provera during the first year due to spotting, regular bleeding, and or continuous bleeding. These side effects are especially common during the first 3 months. Some studies also shows that some women gain an average of 5.4 pounds the first year and 8.1 pounds by the end of the second year.
Desogestrel Cerazette. Cerazette is a contraceptive pill known as a progestogen-only pill or mini pill, and is used as an effective means of birth control to prevent unwanted pregnancy. Cerazette contraceptive pills are particularly useful for women who are breastfeeding and also for women who are unable to use estrogen-containing contraceptive pills or do not wish to take estrogen because of its associated health risks. Its advantages are as follows. Can be taken even if certain health conditions prevent you from taking other types of birth control. It can be used immediately after giving birth if not breastfeeding. Its disadvantages: it is less effective than the combined pill as a contraceptive. It is only available at prescription, and it may result in spotting or irregular vaginal bleeding.
Next is the hormonal intrauterine device or the Mirena. Mirena is a hormonal intrauterine device that can provide long-term birth control or contraception. The device is a T-shaped plastic frame that's inserted into the uterus where it releases a type of the hormone progestin.
To prevent pregnancy, Mirena thickens mucus in the cervix to stop the sperm from reaching or fertilizing an egg and thins the lining of the uterus and partially suppresses ovulation. Advantages of Mirena. It is highly effective with a 98 to 99% success rate over 5 years of IUD use. It doesn't interfere with intercourse. Fertility returns promptly on discontinuation. Disadvantages of Mirena. Menorrhagia is a frequent complaint, as are dysmenorrhea and polymenorrhea. These are the major reasons for the IUD discontinuation as well. There is a high risk also of ectopic pregnancy if conception occurs with an IUD in situ, though pregnancies are very rare with this method. Also, there is a slight risk of acquiring uterine infection during IUD insertion within 20 days of the procedure. This is increased if the woman is prone of STIs. Women should be tested for gonorrhea or chlamydia before insertion and for any other organisms if they request.
Etonogestrel implant on NXT. It is a contraceptive implant preloaded in a disposable applicator. The implant contains 68 mg of active substance etonogestrel, which is a synthetic female hormone resembling progesterone. It is highly effective, 99.9%. This means that fewer than 1 woman in every 100 using this method of contraception for a year would become pregnant. It is long-acting. It lasts for 3 years, reversible and rapid return to usual fertility. It is inexpensive or cost-effective, and a small percentage of women have no vaginal bleeding. However, it is only available by prescription, and it must be inserted by a healthcare provider.
For the non-pharmacotherapeutic alternatives, it includes abstinence and the use of barrier protection such as condom, cervical cap, or sponge.
What contraceptive method, dose, and schedule are best for this patient? For Plan A, the contraceptive method that can be utilized by the patient is the hormonal intrauterine device, IUD, which provides a long-term birth control. This device is a T-shaped plastic frame which is inserted into the uterus of the female, wherein it releases a hormone progestin in order to stop the sperm from reaching or fertilizing an egg by thickening the mucus in the cervix, as well as partially suppresses ovulation. Moreover, it can prevent pregnancy for up to 5 years after insertion. For the generic name having levonorgestrel intrauterine and a brand name of Mirena, the applicable dose is 52 mg per device, having a release rate of 20 microgram per day. This should be inserted by a trained healthcare provider who is familiar with the insertion instructions of the said device to be able to avoid negative sudden events to occur in the insertion. In addition, Mirena is said to be effective with a rate of 99% in preventing pregnancy, which makes it more effective than the other forms of birth control such as pills, condoms, hormonal patch, ring, or injection. For Plan B, the other contraceptive method that can be utilized by the patient to be able to prevent pregnancy is through etonogestrel implant. This is a contraceptive that contains progestin only and a flexible implant preloaded in a sterile, which is a disposable applicator for subdermal use. It contains 68 mg of the active substance etonogestrel and has a release rate of 60 to 70 microgram per day in a week 5 to 6. And decreases to approximately 35 to 45 microgram per day at the end of the first year. Etonogestrel is a synthetic female hormone resembling progesterone. A small amount of the hormone etonogestrel is continuously released into the bloodstream for 3 years. It has a rod itself which is made of ethylene vinyl acetate copolymer, a plastic that will not dissolve in the body. This is highly effective up to 99.9%, which means that women have a fewer chance of becoming pregnant by using this method. Furthermore, it is a long-acting for about 3 years and is inexpensive, which can be afforded by the users. All healthcare providers should receive instruction and training prior to performing insertion and or removal of this implant. What clinical and laboratory parameters are necessary to evaluate the therapy for efficacy and adverse effects? For Plan A, first, infection preventive measures. Infection mostly occurs on the first 20 days of insertion. With this, prevention through having a screening test would be appropriate in order to make sure that the device is free from contamination as well as it is still safe to be used by the patient. Second, proper patient counseling. Having enough knowledge and information with the device is the best thing that a patient could have, in which it can alarm her for any possible problem that may occur and it can improve patient satisfaction towards the said device. Third, follow-up checkup. Patients should have a follow-up checkup or examination which can be of help in order to ensure that the string from the intrauterine device is still in line. With this, if ever there are missing strings, this could possibly be an indication for displacement or uterine perforation. For Plan B, first, physical and gynecological examinations. Conducting physical and gynecological examinations would help the patient to determine if the implanon upon pre-insertion or the baseline, as well as end of first and third year post-insertion were effective or not. In addition, the parameters of interest were the packed cell volume, PCV, white cell count, serum electrolyte, urea, urate, and creatinine, as well as liver function test. Second, proper patient counseling. Having enough knowledge and information with this method would give the patient an idea for any possible side effects that may occur upon pre-insertion and for the succeeding years covered by it.
Offer adequate counseling regarding side effects and risk. Ensuring that women have all necessary information about side effects can assist them both with method selection and method continuation. Communicate about contraceptive efficacy in a meaningful way. It is important to note that efficacy is not always the most important factor that drives method selection, with issues such as side effects, duration of action, and privacy, which plays a prominent role and is commonly one of the most important factors. Anticipate and address barriers to consistent and correct contraceptive use. Given the high discontinuation rate of many contraceptive methods and the frequency of contraceptive failure, suggesting inconsistent and incorrect use strategies to promote improved contraceptive use following method selection are essential. Counsel about dual protection for women at risk for sexually transmitted infections. When reviewing the efficacy of various methods of contraception for pregnancy, it is important that condoms not be dismissed altogether given their relatively poor effectiveness in preventing pregnancies compared to other methods.
Follow-up questions. What medical conditions can be the cause of breakthrough bleeding? As the body transitions to the new type of birth control, breakthrough bleeding can occur for several months. Women who use birth control pills to miss their cycles are more likely to experience breakthrough bleeding. 3 weeks of hormone pills and 1 week of placebo pills are normally included in monthly packets. Breakthrough bleeding may occur when sexually transmitted infections such as chlamydia and gonorrhea are present. Infections transmitted from one partner to another by unprotected intercourse are known as sexually transmitted infections. Other inflammatory conditions that can cause breakthrough bleeding include cervicitis, endometriosis, vaginitis, and pelvic inflammatory disease. If breakthrough bleeding is not caused by an underlying medical condition, how can it be managed? Any birth control pill can cause spotting or bleeding in between periods or breakthrough bleeding, particularly in the first few months of use. Continuous and extended cycle regimens, on the other hand, are more likely to cause breakthrough bleeding than the conventional 28-day schedule. When taking regular 28 birth control pills on a regular basis, you can experience breakthrough bleeding. Unpredictable bleeding resulting from the use of continuous or extended cycle birth control pills usually decreases with time. In the meantime, continue taking the medication as directed. Breakthrough bleeding is not a sign that the pill is not working. If you stop taking it, you risk unplanned pregnancy. Track breakthrough bleeding in a calendar or diary. Typically, careful tracking offers reassurance that breakthrough bleeding is decreasing. Ask your doctor about taking a short pill-free break. If you have taken active pills for at least 21 days, your doctor may suggest that you stop for 3 days to allow bleeding that resembles a period and then take the pill again for at least 21 days. If you smoke, ask your doctor to help you quit. Women who smoke are more likely to experience breakthrough bleeding than the women who do not smoke. Contact your doctor if the breakthrough bleeding becomes severe or lasts longer than 7 days. Other potential causes of breakthrough bleeding, such as infection, may be considered. Your doctor may suggest an alternative form of contraception depending on the circumstances. What recommendations can be made to address this patient's complaint of worsening acne? Acne may be mild or severe. Acne that is mild can only require over-the-counter treatments. Acne that is moderate to serious can necessitate a prescription from the doctor. Since birth control regulates hormones, it can be used to treat acne in women. This means it will lower the body's level of acne-causing androgens, and this can lead to smoother skin over time. Birth control pills can help if you have acne breakouts during your menstrual cycle.
Listed below are some of the methods of birth control and its cost. The price range for Depo-Provera is 600 pesos to 1,200 pesos per injection every 3 months. Desogestrel or Cerazette. The price for Desogestrel Cerazette is 610 pesos. Next is the hormonal intrauterine device or the Mirena. The price for hormonal intrauterine device or the Mirena is ranging from 15,000 to 20,000, and the insertion fee is not included. The fourth one is etonogestrel or the Implanon NXT. The price of etonogestrel Implanon NXT is 3,000, a professional fee of 1,200, in which 40% of case rate, and 1,800 for healthcare institution fee, in which 60% of the case rate. Among all the pharmacotherapeutics alternative listed above, we concluded that the hormonal intrauterine device or the Mirena is the most cost-effective. Its success rate is to 98 to 99%, which makes it highly effective within more than 5 years of use. Even though it is very pricey, one of its pros is its low maintenance. It does not require the woman to have taken shots every 3 months or buy hormonal pills every month, which is very applicable for those who are busy with their schedule and personal matters. In that way, aside from saving their precious time, they can also save on the additional costs such as transportation and food costs in the process of acquiring the other type of birth control.